lecture, ovarian causes of female infertility. We have gonadal dysgenesis, Turner syndrome, which is 45XO, the most common type, testicular feminization, or premature ovarian failure. Inflammation of the ovary is called opharitis. It can occur to secondary to fallopian tube inflammation or peritonitis. Tubo-ovarian inflammation is commonly associated together and can called salpingo-opharitis, and is commonly associated with intrauterine contraceptive device. Complications of opharitis include tubo-ovarian abscess, adhesion, peritonitis, infertility because of extensive adhesion. Follicular cyst and luteal cyst can be a cause of female infertility. This is also common and constitutes to we have physiological variant and pathological variant of the cyst. Commonly they put a size of 2 cm. Below this size it is functional or physiological, especially for follicular cyst, and above 2 or 2.5 cm it's regarded as pathological cyst. These cysts originated from rupture of Graafian follicles and or the follicles that ruptured and immediately sealed. Microscopically they consist of granulosa cells بالنسبة للfollicular cells follicular cyst, or lutein cells بالنسبة للluteal cysts. They might rupture and produce acute abdominal pain. Polycystic ovary syndrome or Stein-Liebenthal syndrome, combination of these clinical features include oligomenorrhea, hirsutism, infertility, and sometimes obesity. Biochemical tests include increased estrogen, increased androgen, increased luteinizing hormone LH, and decreased FSH. Grossly, the ovaries will increase in size twice of its normal size, gray-white with subcortical cyst. Histologically, there is thickened outer tunica cortical stromal fibrosis, or it is called subcortical stromal fibrosis, beneath which this fibrosis we can see multiple small cysts lined by granulosa cells with a hyperplastic luteinized theca interna. Usually there is absence of corpus luteum. Here we see grossly cortical stromal fibrosis and multiple cysts of different size that's seen in the subcortical area. Microscopically, here we see, in addition to enlargement of the size of the ovary, microscopically we see multiple follicular cysts in the subcortical area, and these cysts lined by granulosa cells. Ovarian tumors risk factors: nulliparous women, persistent high concentration of pituitary gonadotropin after menopause, irritant such as talc or asbestos, family history of ovarian carcinoma, in addition to a family history of endometrial carcinoma and breast carcinoma, because there is an associated genes include BRCA1 gene, BRCA2 gene, hereditary non-polyposis colorectal carcinoma genes. We have these important categories of ovarian tumors according to their site of origin. The most common and predominant type include the surface epithelial tumors. The second is germ cell tumors, the sex cord stromal tumors, and the metastatic tumors, which are rare. The surface epithelial tumors include serous tumor, mucinous tumor, endometrioid tumor, clear cell tumor, Brenner tumor, cystadenofibroma. Germ cell tumor. طبعا the most common ovarian tumors are those arise from the surface epithelium. They account for 65 to 70% of all ovarian tumors. And the least common is metastatic, which accounts for only 5% of all ovarian tumors. The second most common is germ cell tumors, which account for 15 to 20%. These include teratoma, dysgerminoma, endodermal sinus tumor, and choriocarcinoma. The sex-core stromal tumor account for 5 to 10% of cases, and it includes fibroma, granulosa theca cell tumor, sertoli Lydixial tumors. The surface epithelial tumor derived from the coilomic epithelium, and these could be benign, borderline, low malignant potential. Borderline are called low malignant potential or malignant. These borderline tumors are specific for surface epithelial tumor. They are specific for serous tumors and for the mucinous tumors. Serous tumors, most common epithelial tumors, their age of incidence is 30 to 40 years old female, usually cystic and known as serous cystadenoma, or if they are malignant they are called serous cystadenocarcinoma, and if they form a papillary configuration they called papillary serous cystadenoma and papillary serous cystadenocarcinoma. The most common malignant tumor of the ovary is malignant type of serous tumor, which are called serous cystadenocarcinoma. Grossly, they present as cystic, usually cystic, and their size is variable from 5 to 40 cm. They filled with typically clear fluid. It is a serous fluid, and grossly we can see papillary projections or papillary areas, and this represents the solid part of the tumors and the invasive part of the tumor. These papillary structure are more prominent in malignant type of serous tumors. Microscopically, we divide serous tumors into 3 types: benign, borderline, and the malignant tumors. The malignant tumors can metastasize to regional lymph nodes, but even with malignant type, the distant metastasis, hematogenous metastasis or lymphatic metastasis, is infrequent. Prognosis definitely depends on the stage of disease at time of diagnosis. This is benign serous tumor. Grossly, we can see a large cystic structure with a very thin wall. It is paper thin, very thin wall, and before dissection this contains clear serous fluid. There is no area, no solid growth, and with only minimal papillary projections grossly seen. Microscopically, typically serous tumor consists of single layer of epithelial cells without atypia, and typically there is this cilia. This is characteristic feature of benign serous tumor, serous cystadenoma of the ovary. Grossly, this is the malignant type of serous tumor, serous cystadenocarcinoma. We see it partially cystic and partially solid with multiple papillary projections. As we mentioned, it is more common in malignant type of serous tumors. Multiple papillary projections within the solid areas in addition to these cystic areas. Microscopically, papillary serous cystadenocarcinoma consists of multiple complex papillary structures lined by malignant columnar epithelium with atypical or malignant cellular features, and the most important feature to differentiate between the borderline serous tumor and the malignant serous tumor is presence of stromal invasion. Presence of invasion or stromal invasion is a characteristic feature of malignant serous tumor, serous cystadenocarcinoma, while in borderline serous tumor, which is, as we mentioned, low grade malignancy, that it tends to recur but not metastasize, there is no invasion, absence of stromal invasion that is seen in malignant part serous cystadenocarcinoma. Mucinous tumor, we have certain points to differentiate between serous tumor and mucinous tumor. The features that in favor of mucinous tumor is presence of mucus secreting cells microscopically, and commonly they less likely to be malignant than serous tumor and tends to be more multinucleated than serous tumor. We have a term which is known as pseudomyxoma peritoni. This term is specific for ruptured mucinous tumor and cause peritoneal deposits. So mucinous deposits in the peritoneum because of ruptured mucinous tumor is called pseudomyxoma peritoni. And the prognosis of mucinous tumor is known to be better than the serous, prognosis of the malignant serous tumors known to be better than the malignant type. Endometrioid tumors, these could be solid or cystic. They are known as endometrioid because microscopically this tumor consists of glands or tubules similar to endometrial cells, similar to proliferative endometrium. Therefore, they are called as endometriotic tumors of the ovary. Sometimes they originate from endometriotic cyst or chocolate cyst. One of the important complication or poorly prognostic feature of endometriotic cyst that although in low percentage of patients they can develop to endometrioid carcinoma. Brenner tumor, characteristically, it's microscopically consists of transitional-like epithelium, resemble that of urinary bladder. Although most are benign, both malignant and borderline type are seen. So we have benign Brenner, borderline Brenner, and malignant Brenner tumor. Commonly, this tumor show microscopically transitional epithelium. Now, germ cell tumors, we have teratoma, and teratoma divided into three parts: mature cystic teratoma or dermoid cyst, which is على الإطلاق the commonest ovarian tumor and the commonest ovarian cyst, and we have immature teratoma, and we have teratoma with malignant transformation. Mature cystic teratoma, as we mentioned, is the commonest ovarian tumors. It is smooth, grossly consists of sebaceous materials, hair, teeth can be seen grossly. It tends to occur in right and left ovaries in 10 to 15% of cases. Microscopically, we have variable types of epithelium that originate from different germ layers: ectoderm, mesoderm, and endoderm. And but all these types of epithelium are mature embryologically and well developed. But we have in 1% of cases, although it is rare, but it can occur, this tissue can transform to malignant type of tissue. For example, we have transformation of the ectodermal tissue, which contain the squamous epithelium of skin, into a squamous cell carcinoma, or other types of tissues can progress to adenocarcinoma in only 1% of cases. So this is called teratoma with malignant transformation, which is different from immature teratoma. This is typical dermoid cyst. It contains cystic and solid areas. There is the sebaceous material, and hair, tooth is seen. Microscopically, normal and benign skin, which shows the squamous cell epithelium with keratin. The immature teratoma consists of immature tissue, and typically it consists of immature neural tissue. This is immature neural tissue, and we depend on diagnosis. When we diagnose immature teratoma, we depend on presence of this immature neural tissue to say that this is immature teratoma, which is malignant teratoma. And we should differentiate between immature teratoma and mature teratoma with malignant transformation, in which there is a focus of squamous cell carcinoma or adenocarcinoma. We have a special type of teratoma, which is called specialized teratoma, and the example for specialized teratoma is the Cisternae ovary, in which all tissue consists of one type of tissue, which is thyroid tissue, and this thyroid tissue is can undergo all diseases in which the normally located thyroid develop. كل benign tumors, malignant tumors, thyrotoxicosis can occur in Cisternae ovary. Now this germinoma is a malignant germ cell tumor that is seen in young females, and it tends grossly to be solid yellow and white. Microscopically, this germinoma is exactly similar to seminoma that occur or arise from male testis. We see a nest of large round cells with clear cytoplasm surrounded by or separated by fine connective tissue septa that contain T lymphocytes. Its prognosis tends to be good. Endodermal sinus tumor or yolk sac tumor, the most important microscopic characteristic feature of endodermal sinus tumor is presence of Schiller-Duval bodies, and this is similar to its testicular counterpart, and this tumor carries poor prognosis. These are Schiller-Duval body, and these are immunohistochemical positivity for alpha-fetoprotein. Choriocarcinoma is of the ovary is a highly malignant tumor with early metastasis, and sometimes present in combination with other types of germ cell tumors with this germinoma, for example, and they produce or cause elevated serum gonadotropin and elevated serum human chorionic gonadotropin. 6 cord stromal tumors of the ovary include granulosa cell tumor. The most important feature of granulosa cell tumor clinically that it causes estrogen excess. Any features of production, clinical features of estrogen production can be caused by granulosa cell tumor. For example, endometrial hyperplasia, precocious puberty. When they cause endometrial hyperplasia, they cause menorrhagia. Usually solitary, but may be multicystic. Microscopically, the most important is presence of grooved nuclei and collexinar bodies. Here we have grossly a granulosa cell tumor, in which it is partially cystic and contain hemorrhagic areas with the dominant solid areas. Microscopically, we can see grooved nuclei and formation of colexiner body. This arrangement of granulosa cells around a central space is called the colexiner body, and here we have typical grooved nuclei characteristic of granulosa cell tumor. Fibroma is the commonest six-chord stromal tumor that is present during reproductive years as abdominal mass. Histologically, it produces estrogen and leads to abnormal uterine bleeding, endometrial hyperplasia, and subsequent endometrial carcinoma. Fibroma, it occurs at all age group, but peak incidence is in perimenopausal women, and it is usually always benign. And this tumor in its growth and microscopic feature is similar to leiomyoma. It composed of solid firm white nodule grossly. Microscopically, we can see interlacing bundles of spindle cells. The clinical importance of fibroma is that it causes ascites or and pleural effusion, and this is called Meigs syndrome. Presence of ascites and pleural effusion in case of fibroma. This is called Meigs syndrome. This is fibroma. We see circumscribed tumor, which is a white color, nodularity and whorled cut section is grossly visible. This is fibroma of the ovary. Sertoli Lydixial tumor, it is rare tumor, rarely occur in ovary, but their clinical significance is that they associated with androgen hormone production. That's why they can cause symptoms of virilization. Microscopically similar to its testicular counterpart. Metastatic tumors to the ovary. The ovaries are common site of metastasis especially from GIT and especially from stomach. Next comes the colon and breast. We have a specific entity which is called Kruckenberg's tumor. Kruckenberg's tumor is bilateral ovarian metastasis that comes from gastric malignant primary showing mucin secreting cells. Here we have a tumor that is metastasized to the ovary. This is a Kruckenberg tumor. We can see here multiple signature cells. These are the cells with a mucin production. Mucin is produced in the cytoplasm of these cells. The patient has a primary gastric adenocarcinoma and metastasized to the ovary. This is called Kruckenberg's tumor. It is bilateral. Diseases. These includes abnormal trophoblast proliferation, maturation, and neoplasms that derived from trophoblasts. These include partial hydatiform mole, complete hydatiform mole, and gestational choriocarcinoma. The complete hydatiform mole, in which here there is no embryo, and it results from fertilization of an empty ovum that lacks the functional maternal DNA 23X, lacks these chromosomes, and fertilized with the normal sperms. Risk factors include maternal age. Here we have two peaks of incidence. We have low age group under age of 15 and older age group above the age of 40. Also, Asian women are more commonly involved by complete hydatiform mole. Also, history of previous hydatiform mole can increase risk of subsequent hydatiform mole in 20-fold than in normal pregnancy. Pathologically, we have gross and microscopic features of complete hydatiform mole. All villi show trophoblastic enlargement of the villi, and these villi are large, voluminous, like grapes, and are filled with clear fluid. Microscopically, all villi are enlarged with scalloped borders and contain a central cisterna. The central cistern is area of a cellular area. Here there is no cells in this central area. This is important for microscopic diagnosis of hydatiform mole. In addition to that, there is trophoblastic cells proliferation. Partial hydatiform mole, it contain 69 chromosome, or it is called triploidy, and it results from fertilization of normal ovum with 2 sperms. Each one contain 23 chromosomes, so the result is 69 triploidy. Gestational choriocarcinoma. This is malignant tumor that is derived from fetal trophoblast. Risk factors include previous history of complete hydatiform mole. Complete hydatiform mole raise the risk of trophoblastic carcinoma to 2%. High risk in women with blood group A who married 2 men with the same blood group. Grossly, the choriocarcinoma is a hemorrhagic tumor, different size and with prominent areas of necrosis and hemorrhage. Microscopically, it consists of 2 types of cells. We have the multinucleated giant cells, which are the syncytial trophoblasts, and the mononucleated cells, which are the cytotrophoblasts. In addition to areas of hemorrhage, this is aggressive tumor. This tumor tends to metastasize to, or it can invade myometrium. It can metastasize in 90% of cases to lung. Lung metastasis is occur in 90% of cases. Also brain, gastrointestinal tract, liver, and vagina are important sites for metastasis. Here we have an important point to mention is that all tumors that contain or metastatic tumors that contain villus structures are not choriocarcinoma. Choriocarcinoma, the primary and metastatic choriocarcinoma does not contain villus structure. There is no villi. There are no villi in the microscopic examination of all cases of choriocarcinoma. So cases that contain villi, even in the if metastatic, they are regarded as hydatiform mole and not choriocarcinoma.